It's important to perform a thorough lower limb examination in patients with diabetes in order to detect signs of peripheral neuropathy, signs of peripheral vascular disease, any foot ulcers or abnormal weight bearing and risk factors for foot ulceration and infection, and also if the patient is using insulin to check particularly generally over the thighs and buttocks for insulin injection sites, in particular whether there's fat hypertrophy, as insulin will be absorbed more erratically from these sites. Peripheral neuropathy is very common in type 2 diabetes and is often detected in somewhere between 8 and 18% of patients at diagnosis, and even in pre-diabetes, and in one Finnish study was present in up to 42% of patients by 10 years of duration of type 2 diabetes. It's a very significant risk factor along with peripheral vascular disease for lower limb amputation, and is one of the major reasons for lower limb amputation other than traumatic injury. It's important also to inspect the patient's footwear and to check the patient's education about foot care. Okay, thank you for coming in today, Tony. It was very kind of you.
Oh, it's my pleasure.
And as we discussed, I'm going to examine your legs. And first of all, looking at your legs, I can see that there are scars on both legs consistent with having had femoropopliteal bypasses, and another scar suggestive of a lesion having been removed, and a scar over the knee. Having a look at the legs further, there's a loss of the hair, so that there are only a few hairs here, but generally over the legs there's marked reduction in hair growth. There's some venous starring over the ankle regions of both feet, and you'll note that Tony, on his left foot, the big toenail has a fungal infection, is hyperkeratotic, and that's something that, if it's treated, does take a long time to treat. And it's different from hyperkeratosis that's related to neurovascular changes. When I look at the soles of the feet, okay, you'll note that there's an area of callus over the first metatarsophalangeal joint on Tony's right foot, and that is treated regularly, third weekly, by a podiatrist. Also over the third and fourth, it looks like more the fourth metatarsal head, there's a small area of callus. And just now moving to the left foot, there's a minor area of bruising just medially along the big toe, and looking underneath the foot, there's very much less callus than on the right foot, but a minor amount here, again over the first metatarsophalangeal head, and also just over the third MTP joint. So it's important to look for that. Also look to see if there are any cracks in the heels, which need to be treated, as well as checking between the toes. And now inspecting just between the toes, no soreness there? No, just having a look between the toes. The skin appears normal, there's no maceration, and all of the toenails have been cut directly across, which is what's recommended in diabetes to avoid ingrown toenails. That's good. There's a very small area of broken skin of ulceration here, which might be related to a recent injury. Have you injured that bit? No. Okay.
So it might be new shoes.
Could be new shoes, yeah. Certainly going on now to check the pulses. No soreness there?
No soreness.
I can't feel, just posterior to the medial malleolus, I can't feel the posterior tibial pulse. And the dorsalis pedis pulse on the right is impalpable, and just on the left here. Again, the dorsalis pedis pulse is impalpable, as is the posterior tibial pulse. Okay, just checking now for capillary return in the feet to check the microcirculation, just pressing to blanch it and then seeing how long it takes to return. And I'll just do that once more. So it's mildly slow, just a little over 2 seconds, only very mildly delayed. Okay, and now we'll do the left foot, and just checking on the left foot on the big toe. Blanching there. And now return. So it's just really at the upper limit of normal. I'll get you just to lift up your leg a little bit and then relax back onto my hand, and I'm just feeling for the popliteal pulses there. That's good. And just relax again. That's good. I'll check the femoral pulses too. So I'm just going to feel just between the hip bone and the pubic bone to feel where that pulse is. So just feeling the anterior superior iliac spine, and then just feeling the pubic symphysis, and midway between those points, and I can feel that femoral pulse there. You've also got the scar that actually leads to that spot on that side too. Okay, so both femoral pulses can be palpated easily. And another thing that can be done is to listen for bruits. I note also, which I didn't mention before, that there's quite marked wasting of the quadriceps muscles bilaterally. I'm going to go on and test the feeling now in your legs. So what I'll do first of all is just to touch you with a little bit of cotton wool just there on your chest. Does that feel just like a light touch?
Yeah.
And I'll get you to close your eyes, Tony, and just each time I touch you, you feel me touch you, just say yes.
Yes.
And I'm checking in a dermatomal pattern here. Can you feel me touch you at all?
Yes.
Okay.
Yes. 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 Yes.
And okay, and just so Tony appears not to have sensation below the knees bilaterally, although the first time I thought he could feel over the dorsum of the foot. I'm now just going to run the piece of cotton wool just up your leg, and I'll get you to tell me when you can first feel it, and also when it first starts to feel normal.
Yes. Yes. Yeah.
Okay, so where you start to feel it just below the knee, and where does it start to then feel normal to you?
I'd say pretty well just about above the knee.
Just above the knee, okay. And I'll do the same on the left. I'll get you to close your eyes again.
Yeah, that's normal.
Okay, so they're more sort of at the knee. And just checking with a 10-gram monofilament, which I don't expect Tony will be able to feel in terms of the density of his sensory loss. Just with your eyes open, I'm just going to touch you with a little bit of nylon, just a very light touch there. And close your eyes now. I'm going to touch you on your feet with the nylon, the monofilament. Just say yes each time I touch you. And I'm avoiding checking over the area of callus. Can you feel me touch you at all?
No.
Okay. So that's done for completeness, but I wasn't with the abnormality and the light touch. I wasn't expecting to find monofilament present. I'm going to now check with a tuning fork, so 128 Hertz tuning fork. I'm just you're going to feel some buzzing just on your chest to show you what it feels like. You feel that?
Yeah.
And I'll get you to close your eyes, and just when I place it on your leg, just say yes if you feel any buzzing. Any buzzing there?
No.
Any buzzing there?
No.
Any buzzing there?
Yes.
Tell me when it stops.
Stopped.
Okay. Any buzzing there?
No.
Any buzzing there?
No.
Any buzzing there?
Yes.
Tell me when it stops.
Stopped.
Okay, and it's still actually vibrating, so it's diminished there as well. And I'll check your reflexes now and your knees and ankles. Are they sore at all to tap on? Or okay to tap on? You
No,
can
you
open
can
your
do
eyes
it
again
like
now.
that.
Okay, just relax your legs, and I'm just going to bend up your legs. That's good. That's good, so they're actually quite brisk, those reflexes. And we'll get you just to relax your legs now. That's fine. Just relaxing now. Just let your ankle, just knee bend up, and I'm just going to check your ankles. They sore at all to tap?
No.
Nope. And just grit your teeth now. Just grit your teeth or clasp your hands together and pull one or the other.
Like this?
That's good. Perfect. And relax. And just do the same thing again. And relax. And just on this side, just bending up and just relaxing your hands there. And grit your teeth now, or bend or pull your hands. And relax. That's good. And you can just relax your legs down now. That's good. And what I'll do is I'll get you just to lift up this leg on the right, to hold it up straight up, just up a little bit off the bed. That's good. Don't let me push it down. Hold as strong as you can. That's a little weak. It's 4 out of 5. And the same with the other leg. Don't let me push down. Hold it strong as you can. Very hard for me. I think it's a 5. And I'll get you to lift this leg a little bit off the bed. Push your heel right down into the bed as hard as you can now. Good. That's 4+ out of 5. And just the same with this one. Push your heel as hard as you can into the bed. Okay, and that's 5. Just bend up your legs a little bit at the knees. Just a little. That's good. And don't let me straighten your leg now. You hold it bent as strongly as you can, and don't let me straighten it. Good. And the same on this side. So power is 5 out of 5. And pushing your leg straight, now as strong as you can on the right.
Am I allowed to jerk it? Or must it feel steady
That's
pressure?
Cheating. Steady pressure. Push it out straight. Good to check on the rules. That's good.
Yeah.
And this one now, push it out as strong as you can. Okay, that's good. And just bend your feet back like that, so normal power there. Don't let me pull them down. Hold your feet up as strong as you can like that. That's good. And push down now as hard as you can. Good, that's excellent. So on inspection of Tony's shoes, he's got well-fitting, closed-in shoes which have good supports, and he also has orthotics which allow and maintain fairly normal weight bearing through his feet, or as normal as can be maintained under the circumstances. And just checking inside them, there's no sharpness, there are no lumps there, and you can see the orthotic sitting in that left shoe. Thank you for coming in today, Ken.
Pleasure.
Very kind. Thanks. So in terms of inspecting the legs, in terms of inspecting them in entirety, first of all, I'm looking for scars, and we can see some scars related to vein harvest previously on the left leg. I'm also looking to see whether there are any fasciculations or any muscle wasting, and it looks as if there's mild wasting of the quadriceps muscles bilaterally. Looking further down the legs, you can see that there's from about the mid-shin bilaterally, there's loss of hair, and there's dryness of the skin of both legs, particularly from the knees downwards. The toenails are hyperkeratotic bilaterally, particularly the big toenails, but you'll see that they have been cut directly across, which is important in diabetes to avoid developing ingrown toenails over time. Okay, and just looking at Ken's feet, looking at the soles of his feet, you can see that there's no apparent marked callus at the moment, but he's just recently been to the podiatrist, and you can see an area where callus has been removed here and also here. It's very important to look and see whether there are areas of abnormal weight bearing, because when people have peripheral neuropathy, they can certainly develop ulcers under areas of callus if they're not dealt with appropriately. So just here, there's an area of callus just over the tip of the big toe, and it's more marked, and you can see hyperkeratosis of the toenail, and also on the left side, but that's certainly less marked. And I would be suspicious that Ken's shoes might actually be a little bit short for his feet, but that he can't feel that, and that might be causing the callus. Alternatively, as he has confessed to me, he walks around barefoot at home, and so it might be related to trauma to the end of the toe, but I suspect the former is more likely. Just inspecting Ken's legs, it's very clear here that there is no hair below the lower third of the shins bilaterally, and that relates to neurovascular changes, and also that there's quite marked dryness of the skin and it appears a little atrophic on both sides. There are also some changes suggestive of some early skin cancers there, and changes related to sun damage too. And you can note again the marked hyperkeratosis of the big toenails bilaterally. And a little bit of changes in the appearance of the toes, particularly on the left. It's not exactly clawing, but there is an abnormality in the toes on the left. So in terms of, it's important also to inspect the shoes, because you want people who have peripheral neuropathy to be wearing closed-in shoes where the toes are protected, and also be wearing a shoe that's very well fitting and supportive. And these in fact are excellent shoes for that purpose. It's important also to check inside the shoes just to make sure that there are no areas that are sharp or sticking out, because they certainly can also cause injury. And on inspection, it's very important to inspect between the toes, and this is looking to see whether there are any signs of maceration of the skin or of interdigital tinea, fungal infection. And the reason why this is very important to notice and also to treat is that it's a very common portal for infection and for patients developing cellulitis of the legs, and that looks entirely normal. Going on then to examine the pulses, the dorsalis pedis pulse can be felt just lateral to the extensor hallucis longus. And in Ken it's just palpable, but it's weak, and then the dorsalis pedis is palpable just posterior to the medial malleolus. And again on the left leg, the dorsalis pedis is only just palpable, it's markedly reduced. And the posterior tibial pulse is impalpable. Then checking for capillary return in the feet, I would normally check over the big toes, but I can see there is actually some callus over each big toe, so I won't check in that area. And checking to see how long it takes for the colour to return, and that's within 2 seconds, so that although the pulses are reduced, the microvascular circulation there, it's actually a bit slower. The microvascular circulation is pretty close to normal. And in terms of examining pulses further up the leg, the popliteal pulse, I'll get you just to relax your leg, Ken, and just let me feel just behind the knee. The popliteal pulse is best felt with the patient with the leg relaxed onto your hand. And it's palpable, but again, it's not easy to palpate. Generally, if the pedal pulses are absolutely normal, I won't check as a routine further proximally up the leg. And it's poorly palpable. The femoral pulse is palpated halfway between the anterior superior iliac spine and the pubic symphysis. So just feeling here and checking for the pubic symphysis there. And obviously I have warned Ken before that I'm going to do this. But you need to warn your patient beforehand. And better exposure would be better, but this is adequate for the purposes of this. Okay, that's fine. I'm just going to check the sensation in the legs, the feeling in your legs, Ken.
Right.
So just with a little bit of cotton wool, that's a very light touch. Can you feel that?
Yes, I can, yeah.
Okay, I'll get you to close your eyes now and just say yes each time I touch you with the cotton wool on your legs.
Yes. Yes. Yes, on the top. Yes. Yes.
So I'm checking dermatomally here.
Yes. 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 Yes.
And it's also very useful as well as checking dermatomally. So there's clearly loss of sensation on the soles of the feet. Not so much. I'll check again just on the left. Can you feel me touch you at all there?
No.
No? Okay. And I just want you to tell me now, as soon as you feel me start, you feel the cotton wool, and then once it actually becomes normal, say, tell me again.
Yes, I can feel that. Yes,
Okay.
that's normal, yep.
So are those two different places? So you can feel it just at the ankle, and then does it change again and become stronger?
Yep, yes it does.
Okay. So you've lost sensation really below the ankles there. The same on the left side. Tell me again.
Yes. Yes, that's normal, yep.
Okay. So there's still he can't feel below the ankle, and then from just the upper part of the shin above that it becomes normal. I'm going to check now. You can open your eyes.
Right.
Just with this little bit of nylon, which feels it's a very light touch.
Right.
Like that.
Mm-hmm.
This is a 10-gram monofilament, and it's basically a very light touch. And if it cannot be felt by the patient either when you put it on or as you take it off, then it's an indicator that the patient's at risk of injury. And it's very important that they inspect their feet daily for any sign of injury. Just relax your feet there, Ken, for a moment. That's good. And I'll get you just to say yes each time I touch you.
Yes, I feel that in the big toe. Yes.
And usually the sites which are generally checked are over the first metatarsal head, the fifth metatarsal head, and often over the big toe. And if any of those sites are abnormal, monofilament testing is considered to be abnormal on that foot. I'm now going to test with a tuning fork to test vibration. So I'll just test that first of all on your breastbone there. We usually test on the sternum first of all. Any buzzing there?
Yes.
That's
yes,
good.
very much.
And I'll get you to close your eyes and just tell me if you can feel any buzzing now. Is there any buzzing there now?
No.
So first metatarsophalangeal joint, then medial malleolus. Any buzzing there?
No.
Tibial tuberosity.
Yes.
So you can feel it there.
Yes.
That's good. Again, tell me when it stops now.
Yes. Stops.
Okay. And checking on the left leg. So first metatarsophalangeal joint. Can you feel any buzzing there?
No.
And just checking over the medial malleolus.
No.
And the tibial tuberosity.
Yes, I can feel that.
Tell me when it
yeah.
stops. Still going?
Stopped.
Stopped. Good. Okay. So there's quite marked impairment of vibration sensation there. It should normally be felt at the metatarsophalangeal joints. And if you find it to be normal at the metatarsophalangeal joints, there's no value in going further proximally. So I'll get you now to relax your legs. Just relax them there, that's good. And I'm just going to check your reflexes there, so just tapping over your knees. And just grit your teeth now. And relax. And grit your teeth again. And relax. And I'll get you just to relax, and I'm going to tap over your ankles now, so that the right knee jerk was present and the left one was absent. And just going to tap over your ankle now, and just grit your teeth and relax. And I'll do the same on the left. That's good. And grit your teeth and relax. And the left ankle jerk and the right are absent. So now we'll go on and test power. There is some mild wasting of the quadriceps muscles bilaterally. First of all, I'll get you to raise your right leg off the bed and keep it up off the bed, and don't let me push it down. Hold it as strong as you can. Okay, so power's 5. The same with the left leg. Don't let me push it down. Hold it as strong as you can. Fantastic. Now push it as hard as your heel as hard as you can into the bed. Okay, power's 5. Push your heel as hard as you can into the bed. Okay, 5 again. And you can go on and test abduction and adduction, which we don't need to do for this purpose. I'll get you to bend up at the knee both sides. That's good. And don't let me straighten your leg. Keep it bent. That's good. Again here, don't let me straighten your leg. Keep it bent. Good. Now what I'm going to get you to do is push your leg straight on the right. Okay, push your leg straight. That's normal power. Bend your feet back like that. Don't let me push them down. Good, push them down as hard as you can. Good, and don't let me push them up. Fantastic. So power is absolutely normal. Thank you very much. So in summary, Ken has quite significant peripheral neuropathy with loss of light touch entirely below the lower part of the shins, and hyperkeratosis and skin changes related to peripheral neuropathy. And he's got loss of vibration sensation to the tibial tuberosities bilaterally, and loss of right knee jerk and both ankle jerks. And he also has markedly reduced pedal pulses. So he's got both signs of both peripheral vascular disease and peripheral neuropathy. Thank you. Thank you for coming in today, Kathy. What I'm going to do is examine your legs. And so first of all, just on inspection, the muscle bulk appears normal. And the only scars I can see are a scar over your knee here, and just 2 small scars just above the knee. Looking at your feet, the skin appears normal and the nails appear normal, and we usually will cut them straight across. Nails and diabetes, I can see that there is a small wound, small laceration just over the pulp of the right big toe, and the soles of the feet appear normal. No fasciculations, and muscle bulk is normal. So just inspecting now between the toes. I'm just going to check between your toes there. So that appears normal. That's good. And I'll check the pulses over the dorsalis pedis. And posterior tibial. And dorsalis pedis on the left. And posterior tibial. And just checking the capillary return in the feet. I won't do it on that right big toe. And so that's normal, under 2 seconds, and I'll just check on the second toe on the right. And that's also normal. So in terms of checking sensation now, I'm going to just touch you, just a very light touch with a piece of cotton wool. And I'll get you now to close your eyes, and just each time I touch you, just to say yes. 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 And so just checking dermatomally there, it all appears to be normal. And I'm just going to get you to close your eyes again and just run the cotton wool up your leg. And if you can just tell me from the first moment you feel it, and tell me whether it changes at all going up your leg. No. That changed substantially?
No.
No. Okay, it's always worth running the cotton wool up the legs, because sometimes sensation can be intact but still reduced, and you still have a stocking distribution of sensory loss. Now this is a little bit of nylon called a monofilament. I'm just going to touch you with this, just a very light touch there. I'll get you to close your eyes and just say yes each time I touch you. Yes. 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 Okay. And I'm also going to check just for vibration sensation. Any buzzing there? Yes, that's good. I'll get you to close your eyes and just say whether you tell me whether you feel any buzzing. Yes. Tell me when it stops. Now. Any buzzing there? Yes. And again, tell me when it stops. No. Good. Okay. I'd go on normally and check power, but power is normal, so in this situation I won't. And in this situation, in terms of checking the pulses, I didn't go on to check popliteal and femoral pulses, because the pedal pulses and capillary return are entirely normal. I'll get you just to relax your legs now. I'm going to get you to bend them up, and I'm going to check your reflexes. Any soreness over your knees or over your ankles? No. To check them? No. Okay, I'm just going to check there. And contracted there. And good contraction there. And just take over and good contraction of the calf muscle, and here as well. Good. So thank you very much. Thank you.